You can live essentially a normal length of your life, even with dramatically lower levels of testosterone or estrogen. If you lose your cortisol levels, you're going to be dead in about 72 hours. So it's like, what's the stronger hormone?
Welcome to the Dutch Podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jacqueline Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. This information is not to be interpreted or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, and treatment. Hi there, welcome to today's episode of the Dutch Podcast. Now, as you know, the Dutch test, we really focus in on hormones, stress hormones, reproductive hormones, but some of the additional markers we have on the test do look at additional elements that are related to that experience of hormone patterns. And those include some of the things that are on our OAT panel that are related to neurotransmitters like dopamine, serotonin, norepinephrine, and epinephrine. And so today's guest is actually a specialist in those neurotransmitters. He's a chiropractor by training, but uses the Dutch test with patients that have high and low dopamine to really help rebalance neurotransmitters. So it's a really unique perspective on how to use a Dutch test. And I learned a lot from today's episode in speaking with our guest. The guest today is Dr. Andrew Rostenberg. He's the clinic director of Red Mountain Natural Medicine in Boise, where he integrates chiropractic care, applied kinesiology, and functional medicine to really work with patients to uncover root causes and help optimize their health. He has a ton of experience in genetics. He's the founder of Beyond MTHFR and author of Your Genius Body, reflecting his pioneering work understanding methylation, genetics, and lifestyle-based interventions. He's got experience treating everyone from elite athletes to those with complex autoimmune and neurological conditions, and really emphasizes personalized care that is focused around supporting detoxification, hormone balance, gut health, and brain optimization. And we actually touch upon all those topics in today's podcast. So if you're a listener who is a clinician who's working with patients with mood challenges, or maybe just a patient who experiences that yourself, I think you're going to like today's episode. So let's go ahead and dive in. Well, Dr. Rostenberg, it's really great to have you back on the podcast. Thanks for joining me today.
Thanks so much for inviting me on.
So I'm excited to talk to you about something that we haven't really chatted about on the podcast before, which is really the application of the Dutch test in light of like things like neurotransmitters, which are related to mental health and how our brain work and our stress responses. And we do have certain markers on the Dutch test to cover that, but it's not something that we chat that much about. But tell us a little bit about your thoughts about neurotransmitters and kind of how they apply in your practice, just to kind of kick us off and give our listeners a framework of your point of view.
Absolutely, Jacqueline. Thanks. People don't feel well, they go to a doctor. The feelings we have in our mental landscape is dramatically influenced by neurotransmitter levels. My own personal history as a not so healthy child, young adult, teenager, and everything. I mean, I had neurotransmitter issues myself as part of my interest. And so early on in practice, I dove into this subject, and one of my teachers, Dr. Bob Rakowski, he's out of Houston. He was a big AK and functional medicine doctor for a lot of years, toured around the country and everything. And I got to learn a lot from him. And he gave a model of a bell curve that you could really understand human physiology on a bell curve. We could, in other words, there's such a thing as too much blood pressure. There's such a thing as too low blood pressure. There's being obesity on one end and being sarcopenic and too under, having not enough body fat on the other end. So really every process that we look at in clinic is a bell curve. And so neurotransmitters always interested me because of my own personal health challenges and stuff in my family history. And lo and behold, the neurotransmitters fit this bell curve model very well also. So that's something I'm excited to kind of share with you guys and show you how the Dutch test is a tool that I use to help figure out where they are on the bell curve and then what to do about it. So,
well, let's start with a little bit about understanding how neurotransmitters fit into that bell curve picture. I really like that model. Tell us a little bit more about that.
Well, it's first of all good to have a model that we can visualize, because so much in functional medicine is invisible. It's like under a microscope, it's inside
Mm.
of the dark recesses of our tissue, so it's not just hard for patients. I think it's challenging for practitioners. So anytime we can pull on a thread and connect something that's simple to look at on paper and project it back into like the clinical picture that we see, it's really useful. So in the realm of neurotransmitters, I'll use this analogy of like the vagus nerve. So I've been recently reading the polyvagal theory by Dr. Stephen Porges' incredible book. It's awesome. Anybody out there interested in the vagus nerve, I'd say go jump into that. But he points out that 80% of our parasympathetic nervous system comes from just one nerve. So the vagus nerve is responsible for 80% of our PNS. And in school, because we get multiple choice questions and we learn all this stuff, nobody explains to us that, yes, there's like dozens of neurotransmitters, but the vast dominance of our consciousness is really controlled by dopamine. So in the
Mm.
same way that the vagus nerve this one nerve controls this whole system, dopamine is really rules the roost in terms of our human consciousness. So it has this massive influence on our whether we're going to be depressed or anxious, have food cravings, have high risk behaviors, be combative with our parents as a child, or whether we're going to be have low stress tolerance as a grown up, and start to have even psychiatric effects of just living our life. So I find it fascinating that dopamine has such a big influence. And so the dopamine bell curve is basically the model I'm introducing here. And estrogen and dopamine have this absolutely amazing relationship, and that's where the Dutch test and all the education you guys are doing comes in handy, because you can bring in the hormones and the neurotransmitters. You see where they connect, and so you're not just dealing with neurotransmitters, you're also having to appreciate hormone levels in order to balance the brain chemistry.
Mm. So tell me a little bit more about the connection between dopamine and estrogen or estradiol.
So fascinating concept. And again, please, for all of those of you listening, this isn't like I'm just articulating the dimorphic differences between men and women. Okay, X and Y chromosomes. There are some physiologic differences that play out over our lifetime. So when estrogen is elevated, it is also going to elevate dopamine. So the way to understand estrogen in terms of our mental landscape and then clinically with neurotransmitters is estrogen is an incredible antidepressant. It's amazing. It slows down the metabolism of dopamine through COMT, and it also slows down the metabolism of dopamine through MAO. So we're looking at estrogen as like it's modifying the metabolism of our neurotransmitters. And so when dopamine is low or in shorter supply, an adequate supply of estrogen tends to lend support to dopamine and get it off the low end of the bell curve into the middle, where our brain and our frontal lobe is just working really well. But the flip side to this, if we extend this logic out further, we have so many women, especially, but increasingly more men, who are estrogen dominant, not just the estradiols that you mentioned, but the xenobiotic estrogens, the estrogens in our products and our environment. And so those estrogens have a kind of an additive effect. So if you have a normal dose of an antidepressant, you get a change in neurochemistry that can be beneficial. But what if on a Dutch test we see someone whose estrogen is 50% higher in the upper limit of normal, 50% beyond the upper limit of normal for estradiol? Now you've got like a supraphysiologic dose of an antidepressant that clinically will be dragging that dopamine level way past the optimum part of that bell curve. What are the consequences for us as clinicians and our patients? So I think it's good that we're talking about this, because it is affecting our wives, daughters, mothers, it's affecting men, but certainly to more of an extent it affects women.
Yeah, I mean, when you describe that, if it's pushing the dopamine higher, you would think that would have an overall beneficial response. But with your bell curve assessment, obviously what you're seeing and what we see clinically is that when estrogen gets too high, people don't feel so great due to many factors, not just dopamine reaction. But can you talk a bit about that?
Yeah, I think the idea would be it's not a linear relationship. Going back to these other models that we touched on, like it's not a linear relationship that says somebody with hypertension, maybe they're 160 over 100, that the doctor says we need to lower your blood pressure. Well, he doesn't mean in a straight line until it's 70 over 30. Like that's a problem, right? So the bell curve has this physiologic optimum. And the same thing's true of dopamine. While low dopamine presents a unique phenotype and clinical challenges that are reliably there in almost every case of low dopamine, if we have a patient with too much estrogen who's not able to metabolize it, as you can see on the test, you can see that the COMT is inhibiting the movement of that estrogen out. They may be missing a lot of those other support nutrients that are so important for processing estrogen. Yeah, it's not a linear relationship. So like, people are out there they're getting their dopamine hits. We kind of joke about it on social media and you hear people talking about it, but it's not linear. It's not like, hey, if I double my dopamine, I'm good. I want to go 10x next time. It's like you just actually fall off a cliff on the other side. So
Yeah, well, a lot of it is related to the change, right? The way we feel is related to changes and fluctuations. And in fact, the other thing that comes to mind for me when you talk about estrogen and the influence on dopamine is the tight connection between hormonal fluctuation and mood. And a lot of women report that, even within a normal menstrual cycle. But then you think about postpartum, you think about perimenopause and menopause, where you have these even larger fluctuations, where we know there's a tight connection there. And the data looking at things like PMS and PMDD, premenstrual dysphoric disorder, which is kind of a more severe form of PMS. It's so interesting because what we see, people always assume there must be a hormonal imbalance. But what the data shows is actually oftentimes there is no hormonal abnormality. It's just an abnormal neurotransmitter response to a normal hormone fluctuation in the cycle. Now, can you talk a little bit about what you see there? I mean, could that be related more to metabolism of hormones or other genetics that get involved? The responsiveness of our neurotransmitters to hormone fluctuations. Do you have any more insights into that?
that's a great question. And thanks for bringing that up. So in clinical experience, in the cases of PMDD that I've seen and worked on, the general best practices has always been to help these women metabolize estrogen faster. And to your point that it's not necessarily like a gross super physiologic elevation of estrogen, it's just the way I view it is like these are MTHFR challenged patients. These patients have challenges in the COMT, the phase 2 system of just getting estrogen out. Because what's so unique about female physiology is every 7 days the hormone profile is totally different. So there's so much energy in the background under the microscope that's being spent for that female body to catch up with like the timing that the brain and the physiology is asking for. So just general best practices, if this is something you see in clinic or it comes in, Monday morning, the general thing that I've seen work the best is really high doses of nutrients like methyl groups, B12, methylfolate, B6, of course, but a lot of the phytonutrients, the lignans, the things that are kind of the cutting edge, leading edge, phytonutrients, because that just changes gene expression and it helps remove the estrogen out of the body faster. But to your point about neurotransmitters, looking at pregnancy is really such an interesting physiologic state. And estrogen levels at delivery can be up to 100 times higher than the day of conception. That's just incredible, right? Like, and what does that do to downregulating or upregulating a woman's sensitivity to dopamine? And within about 72 hours after birth, her estrogen is back at baseline. And so if the brain doesn't adapt with its receptors versus the amount of dopamine in that steep rate of change, I mean, that would be an easy time of life for the dopamine system to get out of balance and for symptoms to show up. So
Right. And it's so common for most women. I mean, having been a mother myself, I had kind of variable responses postpartum, but it was a pretty similar experience where, as your milk comes in day 2, day 3, your hormones are coming down. It can be pretty intense and it resolves fairly quickly. So I think you're right. It is this like receptor reset under normal circumstances for most women.
Sure.
Sometimes things continue and perpetuate. And then, of course, we want to make sure women get the support they need when that's the case. But it is a time of that really intense hormonal fluctuation with progesterone and estrogen postpartum. So absolutely a sensitive time as far as hormone change triggering some changes in neurotransmitters. Add that to maybe not sleeping as well, physical recovery of birth, et cetera, et cetera.
Exhaustion, blood loss, fluid loss. I mean, it's amazing what women can go through bringing a baby in. Yeah, it's amazing.
Yeah. Absolutely. Well, I want to talk a little bit about like the catecholamine markers on the Dutch test, HVA and VMA, and how you use those in practice. Like, what do they show you about how the body is coping with stress or recovering on a day-to-day basis?
It's a really nice marker to have. I don't see any reason why you would ever take that off of the Dutch test, because I hope it stays, because it's a good marker. And even if you're just a clinician looking at adrenals and you're throwing in the estrogen sex hormones, because there's just that added value because you lump the test together, save your patients a little bit there. But having a little bit of that final metabolism to look at is excellent, because again, the bell curve model of dopamine is a real thing. Now, in research, they use a term called the inverted U curve, and I call it a bell curve, and they basically mean the same thing. But dopamine has
It
this
sounds like
optimum,
exactly the same thing.
they have this optimum range that they recognize, like symptoms of low dopamine. When you know when you're looking at symptoms of low dopamine, let's say in an initial visit, you're doing your workup, you're putting your clinical hat on, and your patient shares with you that they're sleeping 14 hours a day. They are having severe cravings. The cravings are typically more towards the starches, the carbohydrates, the sugars. Um, they're having a hard time concentrating. They've been diagnosed with ADD, ADHD. And these are just the most common patterns. You get these patients all the time in clinic. And so I'm obviously usually like most of us, we're talking to patients and beginning that clinical relationship before we have a test in our hand. But what's nice about having those catecholamine markers is you just keep it very simple. You have a normal range. Every test you ever get, right? Every test we've ever looked at in clinical practice is itself a bell curve. There's a bell curve to hemoglobin, to estradiol. So catecholamines are the same way. There's that normal range. And so when they're at the borderline or low, there's a clinical indication for intervening there, because those patients they're not going to necessarily raise their dopamine level unless you as the clinician take that responsibility on. And that has to do with the fact that we only make tyrosine and phenylalanine. We actually don't make it. I should rephrase that. So human beings, we cannot make tryptophan, tyrosine, or phenylalanine. I find that to be very unique, because that's like the majority of our monoamines and certainly our dopamine system. So we're dependent on our diet for giving us enough tyrosine and phenylalanine that would come from the protein part of our diet. But we're also dependent on our gut microbiome for producing those amino acids also. And this is not to get too far afield here, but Roundup and the active ingredient Roundup glyphosate, specifically the reason it kills weeds and kills things that are growing is because it stops plants from making the aromatic amino acids, tyrosine, phenylalanine, and tryptophan. So when we are exposing this whole generation, starting around like 2010, to all this saturated glyphosate food, you're seeing that clinically where those bacteria are getting killed and they're not making enough. So I just point, in clinic, I know you're seeing it because I'm seeing it all the time, but I want to give you guys that confidence to say, okay, if the catecholamine markers are low in the Dutch test, it's not just like, don't just breeze over it and move on to the thing that you thought you're going to find. If you're in clinical practice and you get that test back, I can pretty much guarantee you, nobody else in healthcare that they're ever going to see is going to do anything about it, and you might be the only one that makes a difference. So please
Mm.
um, learn more about how to raise dopamine in a healthy way, and conversely, how to lower it in a healthy way. Um, your patients need that.
Do you want to share a couple of the clinical pearls that you have on those?
Absolutely. So being a big MTHFR nerd in my career, just kind of went down that rabbit hole a lot, and in a very deep way. It gets very complicated, but what comes out of it are some really good pearls. And ultimately, what's nice about being fluent with MTHFR and just understanding it is it has a dramatic effect on neurotransmitters. So you you have to see these patients who are coming through your practice. Obviously, look at the estrogen, make sure that that's kind of a separate discussion in its own right, but it's connecting into neurotransmitter and brain balance because of the COMT shared detox pathway. So on the low end of the scale, I'll often see women, for example, with lower levels of estrogen, lower progesterone, lower DHEA pools, and lower dopamine levels because they tend to all drive in the same direction. And when your dopamine is low, the most important thing that you need to do clinically is provide a source of tyrosine and provide a source of methyl groups that are used in the chemical reaction to basically activate neurotransmitters. So back 25 years ago, when methylation just became something that clinicians were starting to pay attention to in functional medicine, it was one of those, like, one of the big reasons why it was discussed was with depression. And you're like, well, why does this affect depression? Well, because again, dopamine is the most important neurotransmitter, just like the vagus nerve is the most important nerve for the PNS. It's a hierarchy, and dopamine absolutely rules the roost. So making sure your patients are getting enough methyl B12, methylfolate, specifically methylfolate by itself. If you had to pick one B vitamin and one amino acid, you give them L-tyrosine and you give them methylfolate, and you will reliably raise dopamine.
Mm.
And it's so fast. People will come back. They'll say in 48 hours, they felt like a different person. So I love working with low dopamine people because I get dopamine from how fast they change.
That's cool. You get the benefit, that natural boost of dopamine. That's great.
100%. Yeah.
Now, you've talked about COMT a few times, and this is a genetic SNP or genetic pathway that really connects stress, chemistry, and hormone metabolism. In like the most simple terms, can you explain a little bit about that? Why it's important and what happens when that pathway is either slowed down or it gets overwhelmed, which can be genetic, it can be lifestyle related. I just want to kind of give, because you've talked about COMT a few times, and I want to just make sure that our listeners kind of know what we're talking about there.
100%. Yeah. I think metaphors are really helpful when you're talking about the nerdiest stuff out there. Um, so COMT is just an acronym for a long chemical name of a chemical reaction that has to take place in order for us to remove things from our body. And specifically, it has to take place to remove estrogen, and it has to take place to remove adrenaline and dopamine, which is just fascinating because, like, dopamine and adrenaline are these key markers of stress and in our brain chemistry. And then, you have estrogens having this big influence on hormone pathways. So the analogy I think that makes the most sense is to think of parking spaces. I don't live in Manhattan. I would never drive a Suburban full of 8 people down into downtown Manhattan and look for a parking space because there's not that many available, and that would be a very painful, expensive, and confusing experience. But in your body, if you're born with 2 copies of this COMT variant, or as you mentioned, Jacqueline, that there's some environmental challenges, nutritional deficiencies, etc. If this is going slower, if your COMT is slowed down, it's analogous to being downtown Madison Square Garden, just exits, and you're driving to try to park your big vehicle. So that's kind of what your estrogen molecule is trying to do. It's trying to find a parking space. So is your dopamine, and it's all about traffic. So when you have these genetic challenges at that particular COMT point, the traffic is heavy. And so you have to drive around the block listening to a great podcast on functional medicine for 30, 45 minutes or an hour before you can park your vehicle. And that's the analogy of what's happening in the liver. So with these genetic variants, the COMT specifically, it might be that when you release dopamine, instead of only being in your body for, a half-life of 3 minutes, your half-life might be 5, it might be 7. And so you're going to have an outsized response to stress if the dopamine sticks around too long, and the adrenaline as well. And conversely, if you don't have enough estrogen, you could potentially have really low dopamine and you can't keep it in your body at all as much as you need. So I hope that it's basically traffic, and when those parking spaces are full, your molecules your body's trying to get rid of are just going to be in circulation way longer than they're supposed to, and those have effects on how we feel and how we handle stress, and they can make your cycle heavy. They could cause clotting, heavy bleeding. You could always be chronically anemic because of this, because no amount of oral iron seems to be enough because of how heavy your cycle is. And we meet patients like this, and we work hard to help correct that. So
we'll be right back. Here at Precision Analytical, we've launched the biggest update to our report since 2013. The new and enhanced Dutch report puts the most actionable hormone insights right on page 1, making it faster and easier to interpret. You'll see a reimagined summary page, upgraded visuals for estrogen and cortisol metabolism, and an all-new About Your Results section, what we call the Dutch Dozen, a 12-point framework that helps you understand your patient's hormone story in minutes. It's a smarter, simpler, and more insightful Dutch experience. From now through December 19, 2025, all registered Dutch providers can order 5 Dutch Complete or Dutch Plus kits for 50% off. Give us a call or visit DutchTest.com/order now. Must be a registered Dutch provider. Promotion not available through distributors. Can mix and match Dutch Complete and Dutch Plus kits. Prepaid only, no drop ships. Cannot be combined with any other offer. Kits must be purchased by December 19, 2025. Welcome back to the Dutch Podcast.
I like your parking lot analogy. And I mean, we think about COMT with predominantly drives methylation. And so it's a really important step of the estrogen clearance process and also other detoxification processes. So is it true that other things can stress that pathway when it comes to detoxification that can actually make neurotransmitter imbalances worse?
For clinical practice, Jacqueline, the trifecta is really, it's dopamine and adrenaline. And when we say catecholamines, of course, what Jacqueline and I mean is they're under the umbrella of the same basic shape.
Right. That adrenaline, noradrenaline.
Yep. And then dopamine, right? So those are all like grandmother, mother, and daughter chemicals. Then you have the estrogens. But what's really fascinating, and this was something that we keyed into in practice about 10 years ago, you have all this gut activity. So you have all these phenol compounds in the gut that go up into our portal vein, which, the main reason the liver exists, you could argue, is to simply like detoxify what's happening in our intestines. That's like one of its main jobs, huge filter. So if our digestive system is imbalanced and there's all this extra, let's say bacteria or yeast, that's flooding in every second, 24/7, taking all the freaking parking spaces up constantly. And now what are you going to do with your hormone levels? Now you're a female, you're 36-year-old female, and you're 7 days away from your menstrual cycle. You should be progesterone dominant, and your estrogen levels in a few days should begin to drop. But because your gut's imbalanced and it's clogging all the parking spaces in COMT, this is why clinical practice in functional medicine is exploding, and it's so important because we can solve these things for people. This can be logically understood and solved, and your test is a real important tool in that process.
Yeah, I love that you bring up the microbiome, because I think when it comes to Dutch testing or estrogen metabolism, people generally recognize that the microbiome has an impact through the estrobolome, right? Through specific dysbiotic microbes creating beta-glucuronidase, which can cause estrogens to recycle. But you're really describing other ways in which the microbiome or a dysbiotic microbiome can really impact metabolism of estrogens and other compounds.
We all know, lay people who don't nerd out on functional medicine, there's commercials educating people that, the gut's the core of your health and all of this. And I remember learning this, and just as a student, I'm like, how do you know that's more true than saying estrogen dominance is the biggest problem? But, the cool thing about practice, and I explain this to patients a lot, and to my colleagues when we're teaching them, like, it's about knowing which layer to peel first. So that's really the experience, what experience teaches you. But for example, if you get your Dutch test back on your patient and estradiol is, 15% out of range elevated high, and your patient goes to the bathroom once every 5 days and has a bowel movement and has been on 45 rounds of antibiotics in the last 10 years, you're going to have to deal with the gut dysfunction, normalize that physiology before you'll really be able to make the deeper change that you see on the Dutch test. That would be my kind of best practices advice.
Mm-hmm.
You, going to the bathroom is phase 3 detoxification. If, as you mentioned, if something is, so like women generally have a predisposition to being constipated. It's really interesting in the research. Women are constipated about 3 times more often than men. And that has to do with estrogen, sort of its effect on the sphincters and the smooth muscles of our GI tract. So a woman who doesn't go to the bathroom, not to get this, I talk about this all the time, so we're just throwing that in here.
Yes,
if you don't poop,
digestion is a common topic. We're not afraid to talk about it
yeah,
here.
yeah. So if you don't go to the bathroom and have a bowel movement, that estrogen that your liver just detoxified is exposed to the bacteria. Beta glucuronidase just undoes everything your liver just did, and now the estrogen goes right back up the portal vein and has to get detoxed again. So in that traffic model, like, yeah, that's creating traffic. So sometimes the simplest thing like that, solving constipation, can move the needle 30 or 40% for a hormone problem, before we get into the more elegant, functional medicine stuff. So
Yeah, I think it's worth talking about. I mean, it's really a foundational aspect of health, and I'm glad that our microbiome is getting the attention, or getting more attention now. And we're learning about not just the gut microbiome, but microbiota really everywhere in the body. And it really influences, when we think about hormone balance, I was talking about this with another doc on our team yesterday. You have like the core hormone production pathways, the hypothalamus, the pituitary gland, and then the end organs that manufacture in response to the brain. But then we have to consider what happens in the tissues, right? And I would call that the terrain. Like, how are they metabolizing? How are they utilizing? How are they metabolizing, detoxifying? And microbiome is a critical piece of that, but also just the tissue health and how metabolism is working on the cellular level is a really important part of a patient's experience with hormones, or, their overall impact of hormones. So I'm glad you bring up microbiome, because it's something that is such a critical piece. You really can't tease it out or talk about hormone balance without thinking about that.
there's some interesting research that I've found over the last few years. They call the microbiome phase 0 detoxification.
Yep,
And I'm
it
like,
makes a
it
lot of
makes
sense.
sense. The second you put something
Absolutely.
in your mouth, it's getting modified, and it's almost kind of incredible that we can eat all these colorful vegetables and things. And like, if your gallbladder stops working, okay, this is something to think about. If your gallbladder stops working completely for 24 hours, when you go to the bathroom, it looks like concrete. And to eat all this pomegranate juice and superfoods and highly phenolic stuff, that we put in our mouth, that are just amazing superfoods and like natural medicine, our body rips that stuff apart so well that gut just breaks it down and absorbs it. There's literally no color left. And all the color in your stool comes from your gallbladder. So of course, if you're having dysfunctional colors of your stool, you need to go see someone like me and get that worked on. But yeah, it's the whole picture. But that's what the public wants, Jacqueline. People have AI now. They're being coached on what to ask their medical doctor, and I think it's creating I think the change is just going to continue to happen across the board. It's going to be really exciting to see
Yeah.
how healthcare gets upgraded.
Yeah, I totally agree. I mean, we've seen that there's been this consumer push to health. I know we're getting a little off topic, but I think this is really interesting. I think providers have to either embrace it. I mean, a lot resist it, right? Because traditionally, when you went into your physician, they were your only source of information and the only ones who had the training to really properly diagnose. Nowadays, I really believe all of the information that all of us know is on the web, right? You could learn every single fact that we learned in medical school, an MD, ND, DC, DO, doesn't matter. All of that information is available online. It's been democratized. The synthesis of it is what physicians learn and what they can do to apply it and help patients get well. But with AI, patients are starting to do that on their own. And I don't think that's for the best. I'm not recommending that people go without a doctor and just use, Grok or ChatGPT to diagnose and treat themselves. But it is allowing patients to come in a lot more informed. And I think it's something that medicine's really been working to adapt to. Of course, there's a ton of direct-to-consumer products and healthcare services and telemed, and we can debate the pros and cons of that. But absolutely, the democratization of data has led patients to want to go a little bit deeper, and they need physicians who can do that with them.
They want a coach also and a quarterback. And I think that's the challenge to your other physicians that you work with and other clinicians, is that we might be specialists in one area, but really, and I come back to this more and more, like I'm basically a quarterback for people. Because of my clinical experience, seeing so much wide variety of different ailments and histamine issues and mast cells and neurologic problems and limbic system issues and PTSD, and what does that do to your gut and your hormones? Like, people need someone to say, you're not crazy. It's not in your head. You don't need a psych med. I may not have this tool exactly in my kit right now, but you can go see this neurofeedback clinic, or you could, just kind of helping people know that, A, they're not crazy, and help educate them about what's going on. I think that truly at a fundamental level, being a doctor is teaching people. So it's never boring. That's for sure.
True. Definitely never boring. Now, I want to shift gears a bit, because when we talk about hormones, we don't always talk about how hormones affect men in the same way that we do women. Can we talk a little bit about like catecholamines like dopamine and norepinephrine and how they play a role in men's mood and things like motivation and overall energy?
I'm happy to step on this landmine. Thank you, Jacqueline, for offering that to me.
Landmine? Gosh, I hope it's not a landmine.
Well, I'm going to have to make generalizations about the differences of the neurologic terrain of the sexes. So it's coming clinically, and it's coming from a place of love. So just keep that in mind. But men are generally grumpy. And there was a movie when we were younger called Grumpy Old Men. It's kind of raunchy, but it's kind of funny. And it would never have sold if it was called Grumpy Old Women. Nobody would have ever seen that movie, because our eyes and our life experience teaches us that, men tend to have this curmudgeon, kind of edge to their life. And and I don't mind that. I think we should embrace it as men. It's just part of how we're made. So it's part of our constitution. But I think it's also good to understand why. Why do we have this generalization that men tend to be grumpy and become curmudgeons as they get older? Well, if you look at lifetime dopamine levels and you track that decade by decade, men start in like the low normal range. And as we go through life, it actually gets lower and lower and lower. And so in order for grandpa to like take a nap every day in his easy chair from 3 p.m. till 6 p.m. and then wake up, eat dinner, do a few things, and then go back to bed and sleep another 8 hours, like that's really only possible because of low dopamine. So what men have as a greater risk than women, all of these, colloquial things aside, the kind of risk that we have for our patients and the men in our lives, men are at risk of having really low dopamine, and that can lead to self-destructive behavior in an attempt to raise dopamine. And it's just this is kind of my clinical opinion, but I think a lot of the stuff, guys just do more dangerous stuff. We die more often. We do stupid stuff. And we're just trying to calm ourselves down by getting our dopamine levels elevated. So when it comes to hormones, circling back, the reason this is such a strong effect in men is testosterone is essentially kind of an anti-estrogen in a way. It's certainly on its effect in our brain. So in the same way that estrogen acts like this wonderful sort of natural effervescence to raise dopamine and be an antidepressant, as long as estrogen levels are within this normal range within its bell curve range, we would expect dopamine to also stay there. But in men, when men have healthy testosterone levels, mid to high range, we actually are going the other direction. Our dopamine levels get out of our brain too fast. And so it's like, you look at boys, I have a 14-year-old, my oldest, and it's like school environment is really good if your estrogen levels are high and you're female, because you're not needing to do anything to raise dopamine. Women, the girls are beating the guys. They're scoring higher. They're more successful in that environment. And so the estrogen levels that, young teenage girls have is raising their dopamine. Now, what are guys going through? The boys are getting their testosterone surges, and now their dopamine levels are going down. So now they can't focus, they can't pay attention. So it's a really great question and an important subject. But in my perfect version of reality, all of these boys that exhibit this behavior at that younger age in life, as young men, they're taking extra methylation support, they're getting extra tyrosine, and when they start misbehaving, you make them go do 10 wind sprints in the yard out front, and that'll raise their dopamine, and they'll be fine for a couple hours. But in men, as we get older, we also need to pay attention to this, and clinically, again, those same things I mentioned before, tyrosine and the methylated Bs are just so important for men. We cannot make dopamine out of the ether. You cannot give someone a homeopathic. I'm sorry, I like homeopathics, but homeopathics are just an energy signature. It can't create an amino acid if the pathway doesn't exist in our bodies, and it doesn't. So I think you have to view men and women with a little bit of patience and a little bit of nuance when you start to look at it through the hormone dopamine connection, that women and men, men are from Mars and women are from Venus. Men tend to have lower dopamine, and it drives a lot of our behavior. So if the guys in your life are driving you crazy, maybe this will give you a little insight into why. And then, of course, women, they're at risk of having too high of levels of dopamine. And there's consequences of that too. So we want to help everybody just be optimal.
Are there any differences in like the patterns that you typically see on Dutch testing between men and women in regards to catecholamine metabolism and like the HVA and VMA estrogen metabolism? Are there any kind of variations that or patterns that you'd see more in men or more in women?
Certainly, I think what you're going to see on the Dutch test is that women who are exhibiting clinical signs of elevated levels of dopamine, which would be symptoms of like insomnia, panic attacks, high levels of like just sort of state anxiety, just like general anxiety.
Yeah. I call it that like stressed and wired. It's like that stressed and wired versus stressed and tired. You guys probably listening could probably relate to one or the other. It's like when you see patients under stress, they respond one way or another, collapse or hyperstimulation.
100%. So yeah, that's an excellent, succinct description of falling off the high end or the low end of the bell curve. But what I like about the Dutch test is that I'm an adrenal fatigue like junkie. I just try to screen everybody for it. I used to have that problem. It is a real clinical phenomenon. There's no surgery, no CPT code for it. I get that. But that doesn't mean it doesn't exist. So seeing the HPA activity on the Dutch test and the cortisol and the free cortisol, that'll also correlate. So what you'll typically see is people who have been in a stressed environment for a really long time, months, maybe years, you're going to see a depletion of, in a female, progesterone. You're going to see lower levels of cortisol. It's at the low end of normal or off the range low. And that will translate down and also pull down your catecholamines. Conversely, when you see the HPA axis on the Dutch test, states of overactivity where the cortisol level is in the 80th percentile or 100 or more, you're also going to see that driving the sympathetic nervous system. You'll see the high catecholamines in that state as well. So it's like catecholamine metabolism. Thing to keep in mind is it's really quick. It's much easier, so much easier to construct a molecule of dopamine than to build a molecule of cortisol. I find this really fascinating, right? You can turn on a dime and dump adrenaline. Boom. It's like within seconds you can just squirt this stuff.
Yeah, we've all felt that. When you like see the police lights in your rearview mirror and you get that rush. Maybe yes. I'm the only one who gets that.
Yeah. Hopefully you begin to, you need to settle down, Jacqueline. We need you, we don't need you in prison. But the thing I teach patients about, and I think it's good clinically to remind ourselves, is that the body works in anticipation. That's so important to keep this perspective. it's it's thinking ahead. When the sun shines, it makes hay. So it makes DHEA when it's abundant and easy to make it. And then it sticks a sulfur group on it to inactivate it, but it's right there on the shelf. You can just grab it. It's like rip the package open and boom, you have DHEA, and you can begin to support your hormone pathways. So catecholamine metabolism is kind of disconnected from that. It's situational. It's the frequency is a lot tighter. But what I love about Dutch testing is it just gives me like, I can look into somebody's 24-hour cycle. I can see if their cortisol rhythm is within the normal rhythm where, the body is releasing cortisol to peak at 9 in the morning, or is it releasing cortisol to peak at 9 at night? And I think it's important as a clinician in this space of functional medicine to be fluent with adrenal function, to be fluent with circadian rhythm, because it's up to us to educate the patient why things are happening. And believe me, what patients do is, this is what I used to do. I knew if I didn't eat food and I kept working on projects, I'd get what's called a second wind. And I thought that was kind of cool that I could just keep going past a stopping point that I should have stopped, but I just kept going because why do I need to stop? It's like I get dopamine from getting this thing finished. Let's go. What ends up happening is you're abusing your endocrine system, and it's kind of like a plane that takes off, and it takes off and it takes like 4 hours for it to circle, hit its destination and come back. So if you push your cortisol levels out of your body, your body can't reel it back in 20 minutes. You have to take the ride, just like we've all felt. If you have you see the lights in the mirror and you start, you have that big adrenaline dump, you could have a rough morning. The problem is over in 30 minutes, but you don't feel normal for the next 8 hours, So I love this conversation. I love hormones and the endocrine system because it is the most influential system. Like, it's the most powerful system in how we feel day to day. The nervous system's big. I'm a chiropractor, of course, it's huge. It's moving information around and processing it. But what we see on the Dutch test, the sex hormones, stress hormones, sets the background tone for pretty much your daily experience.
Yeah, I'm glad you brought cortisol into our discussion because it's something that, we haven't talked about yet today, but certainly is so impactful, to get into that proper circadian rhythm. And the data around cortisol and adrenaline, epinephrine, norepinephrine, all of our catecholamines, in pretty much every single bodily system, it shows a connection where when stress is elevated and those hormones are released outside of a normal pattern or elevated response, you get downstream effects in really every tissue that they've looked at as far as the function of the end organ. There was just a really interesting one that came out around like the innervation of the ovaries, particularly important when we talk about women who are trying to conceive and women who are going through perimenopause and menopause, that actually stress has a effect on the ovaries throughout the lifespan that impacts their function at these key times in our reproductive cycle. Really interesting, data, but the more we look, the more we uncover with that. So I'm really glad that you brought cortisol into the picture because it's such an important part of neurotransmitter activity as well as reproductive hormones.
I sometimes mention to patients that, heaven forbid a woman could experience a full hysterectomy at a young age for some life-saving procedure. We wouldn't ever encourage that, but that hasn't been known to happen. Men have been castrated for different reasons, potentially even just health reasons at a young age. And you can live essentially a normal length of your life, even with dramatically lower levels of testosterone or estrogen. You're not going to be healthy per se, but you can live that time. If you lose your cortisol levels, you're going to be dead in about 72 hours. So it's like, what's the stronger hormone? So
critically important.
Yeah.
Well, the last topic that I want to touch upon, because I know you do a lot of Dutch testing, and I'm sure our listeners are really wondering, like, how do they put this together clinically when they're using the Dutch test? Now, I know we look at hormone activity, neurotransmitter activity. Can you start by talking just generally, like, how do these influence one another, and what's the value in looking at them together when you're looking at a Dutch test?
Well, I think part of what sets our practices apart is we're in the business of understanding why and explaining why. And I think the value of life-saving heroic medicine is you're not looking at someone's estrogen levels when they're bleeding out in the OR, you're just going to keep them alive for the next 24 hours and then hopefully the next 2 weeks. But eventually, once the fire's out, how do we rebuild people? And, are we doing our job in that respect? So your job in the clinical sense is to gain the understanding so you can help patients understand why things happen. And when we have that understanding, our decision making and our accuracy goes way up. And now, as with experience, interviewing people and just listening to their history, you begin to put that together. But it's just really valuable to have in your hand objective data. I mean, I'm a biochemical nerd. I got straight A's in OChem. I mean, I'm weird that way. But I love the fact that, patients who aren't that same kind of person can look at this test and see relationships, and I can explain it to them. But it's just important in functional medicine to remember that everything is connected. We may not, even I, may not even be able to explain all the different connections. Of course I won't, but it's important to understand that when a patient has, estrogen levels, let's say on the Dutch test, that the primary estrogens in circulation, E1 and E2 and E3, are in the normal range for a 36-year-old female, but her metabolized estrogens are really below range. And so then you begin to be able to understand that it's the liver's metabolic pathway. It's the processing of estrogen that's being influenced. So again, everything we work on in clinic, it's invisible, guys. We're not walking into a house and like physically crawling in the crawl space and up in the attic looking for the dysfunction. We have to look at a person. And we need a test that does that for us. So I'm not even sure, blood testing has some value. There's some maybe double checking you would do in blood from what you see on the Dutch test. But ultimately, I'd love to know why things happen. And as good as I am, maybe with my experience, like just talking to patients and hearing their history, it's nice to see levels on a test. So you're doing us a service by offering this test. It's up to us to learn what to do with this.
Yeah, no, that means a lot. I mean, I think when it comes to neurotransmitters, there's a lot of information that you have to synthesize. And the fact that we include a couple of markers on the Dutch test can be helpful. And you just get the patient's clinical picture into place, of course, and looking at things like microbiome. But it's really great to hear reflected back that it's so useful for your practice. So thank you so much. It's been really wonderful having you on today. I always love how you can dive into the biochemistry and make complex things make me become more understandable for our listeners. So thanks for joining me again today, Dr. Rostenberg, and thanks to all of you for listening.
Thanks for having me on, Jacqueline. I appreciate the invitation.
If people want to learn more about you, what are the best places for them to connect with you?
So there's a couple different ways that interested parties can reach out. If you're a patient, I would encourage you to reach out to my my physical clinic. I'm sitting in my treatment room right now. So yeah, we have a brick and mortar clinic, and I'm in Idaho. I'm in Boise. It's a wonderful place, and I see about 80 people a week, and my table's right behind me. That's where all the magic happens. So if you're a patient and you're interested in having someone like with my skill set help you out, love to work with you. And I work with people in 46 states and 14 countries. So we've had 1,000 telemedicine, telehealth patients over the years. So we've got a pretty good system for that too. And then if you are a clinician and you're interested in some of the work I've done, I'm in the process of like curating everything into one website. I got stuff everywhere, but I do teach, and I teach seminars occasionally around the country in person. But I have a coaching program called WellPower. It's called WellPower Practice. If you go to wellpowerpractice.com, you can learn more about that. But I love teaching, and I love helping people. Like, to me, functional medicine is complicated. It obviously is. But the what sets our coaching different is you don't need another degree or 1,000 hours at another institute of functional medicine in order to practice this stuff. You need good coaching and to know how to do things in the right order that helps you get started on Monday morning. And that's my passion, is like leading from the front and like, yeah, we don't need another PhD unless you want to get one, good for you. But most of us just want to like, this tool's amazing. I know it's going to help my patients, but it's complicated. How do I smooth it out and get it usable in clinic? And that's what we really strive to help you do.
Wonderful. Well, thanks again for joining me, Dr. Rostenberg, and I hope you have a great day.
Jacqueline, I appreciate it. Anytime.
Thanks for joining us on the Dutch Podcast. Join us every Tuesday for new conversations with leading functional health experts. If you like what you've heard, be sure to like, follow, and subscribe wherever you get your podcasts.